Okay, today I will talk about the HIV in pregnancy. Okay, so in terms of HIV in pregnancy, what we afraid is a maternal to child transmissions. Okay, right. So, so in how the maternal child transmission happen. So there is a 3 ways of MTCTs happen maternal to child transmission. Okay, so first in utero, in which is a less common because the placenta act as a barrier. However, if there is an impact of the placenta function, the risk of MTCT is increased. The risk of transmission is increased. Okay, and number two is during the delivery. So that is important to decide the mode of delivery and the intervention during the intrapartum management. Number three is a postpartum period, which is advisable to avoid any breastfeedings. Okay, so how we encounter with the patient with HIV in pregnancy. Okay, in the management of HIV in pregnancy. So first of all, you must understand HIV in pregnancy, how to prevent the MTCT. First, there is a 3 way to prevent the transmission rate. First is a antiretroviral drugs, okay, ARV, which contain start or heart. Right. Number two is a management during delivery. Number three is avoid the breastfeeding. Okay, in terms of preconception management, if the discordant couples mean the husband only the HIV positive and the wife is HIV negative. In term of the husband with the HIV positive and the viral load less than 15 and on HART heart, the sexual intercourse transmission is less. Is about 0.01% only to up to 0.03%. So safe sex practice is recommended, which mean they use the condom to sexual intercourse. So how to reduce the MTCT? In this case, we can suggest for ART by donor sperm or sperm washing. Okay, in terms of HIV mother, in other ways, HIV mother is a positive. So first, delay the conception until the HART is optimized, the regime HART is optimized. And then and then number two is after the prophylaxis of PCP is not required at all. And then number three is any opportunistic infection is absent. Okay, high dose of folic acid is required for patient on HRT, especially in on cotrimoxazole. Pap smear yearly is recommended because they are associated with the HPV infection. Okay, in terms of HIV effect pregnancy to HIV, actually pregnancy doesn't adversely affect to the HIV progress or survival rate. Okay, issue of compliance of ARV is present during the first trimester, especially during the nausea, vomiting in pregnancy. So opportunistic infection, we rarely screening or treated because we afraid about the concern the treatment regarding the effect to the fetus first, and then the symptom is mimic like pregnancy symptom also. Okay. In terms of that, the CD4 count during the pregnancy is not affected by the pregnancy physiological of pregnancy. So about the effect HIV to pregnancy, what we afraid is MTCT first. Then the study shows they are associated with the miscarriage, preterm delivery and fetal growth restriction. in view of mother of HIV usually is a poor nutritional status. Okay, and then what you're afraid also is effect of the drug, ARV drug, to the baby. Okay, so the ARV drug is a safety data about the congenital malformation is still reassuring. So the rate especially like previously they say efavirenz is a relative is contraindication, but currently they say it's a safe and no teratogenicity documented efavirenz. And but there is zidovudin, like lamivudin, ritonavir is associated with the congenital malformation also. That's why we must monitoring the toxicity during the antenatal follow-ups. Baseline full blood count, baseline renal profile, liver function test, lactate and MOUT must do before start. Baseline of full blood count, renal profile, and liver function test and lactate is recommended before starting the ARV, antiretroviral drug. Okay, and then after that we monitor monthly and every month about the toxicity. If we suspect any toxicity, derangement, TDM level should be required. So if women on HRT, they are high risk to get gestational diabetic and preeclampsia and preterm delivery also. Okay, so in view of that, during the antenatal follow-up, we suggest to screening for aneuploidy screenings and then anti-screening also. Okay, in terms of ARV, antiretroviral drug, there's two regimes that based on the MOH CPG punya 2008 they recommend that. So in case of the CD4 count more than 250 by the CPG 2008, they recommended to start the start regime, START regime, which is a short term antiretroviral treatment. Okay, it started after the first trimester because it's highly toxicity drug. Okay, it contain of zidovudin, lamivudin, lopinavir or ritonavir. Okay, in term of CD4 count less than 250, HAART is a regime is advocated. So it's a highly active retroviral treatment. Okay, antiretroviral treatment. It contain zidovudin, lamivudin and nefivarin by the MOH guideline. The difference is in the start is we use lopinavir or ritonavir, but in the heart we use navirapin, right? Okay. In terms of management, antenatal follow-up is we screening all the infective screening like HIV, hepatitis B, Hep C, and syphilis. Also, rubella is recommended. It's a multidisciplinary approach which required by the HIV physician, infectious disease, obstetrician, pediatrician. Okay, confidentially is required for this case because we must keep the confidential between the patient. Okay, if they plan to sexual intercourse, condom is recommended for safer practice. Vaccination like influenza, pneumococcal or hepatitis B is recommended. So viral load, some guidelines say viral load monitoring is each trimester, 36 weeks at delivery, but the MOH CPG is every 4 weekly, every month means. Okay. In terms of management. So if patient present of preterm delivery or PPRM, uh, so we may take account about the risk and benefit. Okay, so about the preterm, they are associated with the high risk of transmission. Okay, so AES, uh, if if antenatal corticosteroid is safe and tocilizumab is safe if patient preterm labor and patient present at PPRM less than 34 weeks, so we must consider MDT meeting to consider the time of delivery. So consider the complication of the preterm delivery, like is a prematurity, any neonatal backup present or not, and risk of perinatal HIV transmission. Okay, delivery is expedite if present of coronary symptoms and fetal distress if less than 34 weeks. Okay, if more than 34 weeks, expedite the delivery. So okay, in-term pregnancy. Okay, so the mode of delivery, how we decide the mode of delivery, so it depend on the viral load. So viral load less than 15 is recommended for vaginal delivery, or for patient for vaginal delivery. And then the cesarean section in case of viral load more than 15 or didn't start any HART or present of core infection like hepatitis B, syphilis, right? Number 2, or new onset of diagnosis of HIV during delivery. Okay, so during the, if we plan for vaginal delivery, so is we plan avoid any invasive procedure like fetal blood sampling, fetal scalp electrode. Okay, and then avoid amniotomy if patient present of spontaneous of labor. If this is a induction of labor or augmentation of labor, pitocin and ARM is safe. Okay, so about the instrument delivery during if vaginal delivery is recommended to use the low forceps delivery. Okay, because it's a less trauma to baby. In terms of cesarean section, universal precaution is a highly emphasized during the conduct of this delivery. Okay, cesarean section is recommended at 38 weeks pregnancy because we want to prevent any rupture of membrane or spontaneous of labor. Okay, in this case, if delay delivery by maternal request or any obstetric indication, early cord clamping is recommended. We make sure the hemostatics is very secure. Intrapartum intravenous zidovudine in vaginal and cesarean delivery is highly recommended. Okay, in case of cesarean section, intrapartum zidovudine must started 4 hours before cesarean section up to cord clamping. Okay, during the postpartum management, contraception is highly advisable, right? Breastfeeding is avoidable. Okay, and then we must plan for formula milk by AFAS. Remember AFAS formula. Okay, otherwise about the transmission rate. So that's all about the HIV in pregnancy. Thank you.